and really going to give us a perspective on what he has seen and heard throughout the pandemic. And then we will have two FQHCs really give us some lessons learned and best practices. So Jordan, go ahead and jump right in.
And Jordan, just before you begin speaking, I want everyone on the call to know we're going to record this session for to make available to everyone. So just for your awareness as you remain on the line and as you put questions into the chat function, those will be a part of this recorded content.
Okay, great. So I'm Jordan Berg. I'm the Telehealth Technology Assessment Specialist at TTAC, the Telehealth Technology Assessment Center. We are the National Telehealth Resource Center that's focused on technology. Like Kathy said, today I'm here to kind of talk about kind of some larger trends that we're seeing in technology, some general best practices that we can give you, and then I think the other two co-presenters I have are going to be able to dive into a lot more things that they've experienced and then kind of war stories. So let's talk a little bit about who TTAC is real quick. We are federally funded through the Office for the Advancement of Telehealth to provide both the telehealth resource centers and really the public in general with information about telemedicine technology. We are vendor neutral. We provide, we do our own assessments, but we also teach people how to do assessments. And there's 3 of our staff folks. We have about 50 years of experience in telehealth between all of us. We do a lot of things. One of our major things that we have is outreach. And I just highlighted a couple things here that I thought might be useful for this group. One of the things that we've been doing recently has been our tech talks with the TRCs. You'll see a familiar face in the one there for remote patient monitoring, but these are quick explainer videos that go over some key concepts around some common telemedicine platforms. One of the things that might be really interesting to this group is if you're looking at telemedicine technology, we did a vendor interview series where we interviewed a variety of vendors, talked about questions that they asked, questions that they would like folks to ask when they're being approached. We also provide a showcase where we just demonstrate technology. And then really key to this group is we recently put out a toolkit called our Pandemic Response Plan Project. And it gives you some really good key templates and things that you can use to kind of look at what are the key things I need to do to be ready for any kind of pandemic or other disaster response that you want to address. We are part of the National Consortium of Telehealth Resource Centers. Like I mentioned, we are one of the national telehealth resource centers. We have our regional telehealth resource centers as well. If you go to the NCTRC website, you'll be able to find not only us, TTAC, and the other national policy center, Center for Connected Health Policy, but all of the telehealth resource centers. And these are all great resources. Even if it's not your telehealth resource center, I always recommend that you look at the different sites because they all have a variety of different resources that can help you out. So I wanted to talk just briefly about what were some of the trends that we observed and some of the lessons that we learned and kind of learned from other organizations that were reaching out to us. Right now, folks are in a kind of a reevaluation period. Everyone went from 0 to 60, or for folks that were already at 60, they went from 60 to 90, miles an hour, trying to get telemedicine up and running at the kind of the peak of the pandemic. What we're finding now is people are looking at the solutions that they chose, the technologies that they picked, the platforms, and saying, is this meeting my need? Is this going to meet my need in 5 years? And it's a really good time to look and see do you have the tools that you need? And we find that in both platforms, peripherals, and workflows. Another key lesson learned or trend that we've observed is the importance of support and admin functions. And I think you're going to hear some good stories around this. But one of the things that we found that really worked for a lot of organizations was having staff that are able to do pre-checks for visits. So even before that first initial visit with the provider, calling that patient via whatever platform you're using, making sure that they have connectivity and making sure they understand how the controls for the platform work. And it gives you a chance to do just even a basic broadband check just to make sure they have enough connectivity to support the visit. Another key thing that we found was that it can be really good to have telehealth IT support. And the reason we kind of pull this out separately from your standard IT support is that the needs are really a little bit different for telehealth. If you're in the middle of a telehealth visit, you don't have time to submit a ticket and then wait the 2 to 3 days for that ticket to go through and to be addressed. You need someone who's able to address it right then, who understands kind of the ins and outs of whatever platform you're using and can really just kind of pivot and make that work for you right then. So having those folks. What we found was that we moved a lot of clinicians and a lot of clinical staff into providing care via telemedicine and different platforms, but maybe some of the admin functions and the admin supports that they had in person didn't follow them into those virtual spaces. So making sure that you have all of those support and admin resources virtualized for your providers is one of the key things we can do to ensure success. Another really key element that we need to consider and look at is just general connectivity. So historically, telemedicine and historically the focus on broadband and connectivity has been to the clinical level. Do we have enough broadband connectivity in our clinics? Do we have enough in the schools for our school-based platforms? Do we have enough to whatever clinical endpoint we're working with? Well, that's all kind of changed with the pandemic. We're now reaching out to patients in their homes. We're reaching out to wherever the patient is on their mobile device. So the connectivity to the patient in their home, home as a care-based location, is a really, really key thing. And there's not been a lot of great data around that. Most of the data about connectivity has been reported by the internet service providers directly, and how they're measuring that and what's getting measured has not been super consistent. So there's a lot of interest in how do we improve infrastructure, how do we measure infrastructure, and how do we really make sure that the connectivity we have to the patients in their homes on the devices that they're going to be using is going to be appropriate. The last thing I kind of want to talk on here real quick is hardware. So one of the key things that we learned was that availability of hardware is vital, especially if you're trying to ramp up immediately. I like to call it, we had the great webcam hunt of 2020, where we realized that we needed to move a lot of providers to a virtual space, and we needed to remove a lot of workers to virtual space, but we didn't have the equipment to support them in those locations. So we had, in the organizations I work with, we had IT folks moving laptops from some individuals to other individuals because the need for those other individuals was greater, looking for webcams wherever they could find them, looking for speakerphones. So one of the key things that we can do is to have a stockpile of peripherals and devices that we can use for telemedicine to move that connectivity to the location where these providers are going to be available, so that we don't have to scramble and find these. We know what we have. Another key trend that we've observed has been peripheral connectivity. We've seen a lot of audio solutions, kind of speaker pod devices that have come out, and they have this kind of media, they're kind of dual purpose. They not only want to work as a communication device, but they also want to work as a speaker pod for playing music through or video, audio, that sort of thing. So you can pair them to your phone in addition to plugging them into your laptop or whatever you're using for care. Well, in a pinch, that can be, if you're switching between inputs really rapidly and you're already paired to your phone, we found that can cause problems where you go to connect to a video call and it's not connecting to your computer, it's actually connecting to your phone, and you're having to navigate that. And sometimes that's a little bit challenging. So sometimes when you're picking these peripherals, picking solutions that are a little bit more plug and play, a little bit less advanced, maybe just using USB or just using a direct line in, rather than getting something with Bluetooth that's going to cause some problems. So simple is a lot of times better than more complex. And finally, the last little point we want to leave with is one of the things that we get asked a lot, and talk to people a lot, is what's the biggest bang for the buck thing that we can do to improve our telemedicine applications? And a lot of times that's audio. For a small investment in dollars in audio solutions, whether that's a headset or a speaker pod, you can move away from those laptop microphones that are kind of pictured there at the top. You can create a much better experience for both the provider and the patient without investing a lot of money in your platform. So just a simple USB-based audio solution can really improve what you're doing. Those are kind of some of the key things that we wanted to leave you with, and we want to talk to you about. If you do have questions about the technology that you're looking for, we are a free resource. We're vendor neutral. We are something that's here to help you with your questions. I'd recommend looking at our toolkits as well. They're great ways to kind of go through and help you with your assessment process and look at technology. That's what I had to share for you today. I'm happy to answer any questions.
Great. Thank you, Jordan. I'm not seeing any questions in the chat, but if you do have some, go ahead and drop them in there now. If I don't see anything pop up, I will have Scott get ready to really talk about what some of these best practices were from an FQHC perspective, who had to live this during the pandemic and did a lot of that rapid pivoting that you all have done. So Scott, go ahead.
Thanks, Kathy. Yeah, I'm Scott Wetherill. I'm Chief Information Officer for Verizon Healthcare. We're in FQHC. And before I jump into my lessons learned, I'd like to just take a minute to share some information about our organization. So I'm going to share my screen. All right. Can you see those, Kathy? Super. Yeah, so Verizon Healthcare, we're in FQHC, we're in South Dakota. We were formed in 1978. And right now we have 32 locations, 24 medical clinics, and 8 dental practices. The majority of our locations, go figure, are in very small, rural, and in some cases frontier areas in South Dakota. We are located on 7 of 9 American Indian reservations in South Dakota, and interestingly enough, have a pretty diverse patient population, including American Indians, Hispanics, and we have patients from the Asian Pacific area. As an organization, we have about roughly 300 employees and see roughly about 100,000 encounters per year. Verizon, we have a long history of telemedicine, and it was telemedicine that brought me to the FQHC, interestingly enough, back in the early 2000s. I had been working for the PCA at the time and co-wrote a telemedicine grant for Verizon, and it was funded, and they needed someone to oversee the project and help with some day-to-day IT stuff. So that's when I came on board way back in, like I said, the early 2000s. Through this effort, way back then, we connected our patients to specialty clinics that were part of a larger health system. So we provided specialty services such as cardiology, pulmonology, oncology, dermatology, and infectious diseases, and so on. And so we had a fair amount of telemedicine experience prior to the pandemic, and all sorts of different technologies that we used over the years, and a lot of it was extremely expensive. And fortunately, we leveraged grant dollars to subsidize that equipment. We have had a lot of really good luck with USDA's distance learning and telemedicine grant, and I think we've had at least 10 of those grants over the years, and that's really helped us out immensely. Of course, with this telemedicine model, it included the patient coming into our clinic and then our nursing staff presenting the patient to either one of our primary care providers or a specialty provider outside of our network. So when the pandemic hit, we were charged with seeing patients in the virtual visit scenario, where the patient was at home, and in some cases, both the patient and the provider were at home. And I, of course, immediately thought, hey, we've got this all figured out. We've been doing telemedicine for years, but boy, was I wrong on that front. We really were in the same boat as most FQHCs that had little telemedicine experience, and really had to build our program from the ground up in a very short period of time. I guess with that, the lesson learned in my mind is that telemedicine flavors, there's a lot of different flavors out there, and there's really no one size fits all solution. So as far as the virtual visits, of course, we were positioned to stand this up very quickly over a 2-week period of time. We tried the EMR system. It had its own kind of baked in telemedicine solution, and gave that a run. And unfortunately, it did not go well. In fact, it only had connected maybe 45% of the time during that testing process. So we abandoned that whole idea quickly. But I don't think we were alone. It seems to me like I've heard, even from some of the larger health systems in South Dakota, that they ran into the same situation where they immediately went to their EMR for a telemedicine solution, and then what was offered was really not very adequate. But to, I guess, our EMR's credit, the vendor, I know they've been developing this, improving it, and I do believe the product is better. In fact, we do need to take some time to revisit that, in my opinion. But so after a week of testing, we switched to WebEx. Fortunately, we had WebEx already vetted and integrated into our network for behavioral health visits, and had that WebEx licensing, again, that was subsidized through our latest USDA distance learning and telemedicine grant. So we were fortunate there just to have the WebEx available. We had used it and it was paid for. So that, again, helped out greatly. Also, it met HIPAA requirements. I was pleased to see that the system was very secure and they had the BA agreement available, Cisco did. And so, of course, that helped on the compliance standpoint. So we began developing workflows for both our staff and patients as far as scheduling and connecting that virtual visit using that WebEx technology. On the hardware side, all our providers had laptops with built-in cameras and microphones. However, our laptops, unfortunately, were aging. They were old, and a lot of them were outside of their warranty, and we discovered that after testing, a lot of the microphones didn't work or the cameras weren't working. And so ultimately, we ended up purchasing webcams. We kept the webcams standardized with what we were currently using. We had webcams at the front desk for patient pictures. And so what we did was just we bought the same model just to keep that standardization across the network from an IT standpoint. So I guess the lesson learned there, in my mind, is not to trust your onboard technology necessarily. You definitely want to test that equipment. It's not always bulletproof. And of course, standardizing that equipment as much as possible throughout your clinics is, I think, hugely helpful, especially to your IT support. We also issued our providers 2 external monitors with a docking station so that they could chart at the same time as seeing the patient. So that, I know, was really well received among our providers. When our providers were at home seeing patients virtually, they had to connect to our network via VPN just to pull up the EMR piece. And I do know we ran out of those VPN licenses in our firewall. So that was kind of an unexpected hurdle. Lesson learned on our part was we weren't really positioned to bring in those staff remotely through our firewall, and really needed to acquire some VPN licenses very quickly. But what was interesting, I remember back when our providers were rolling into this virtual visit concept, a lot of them, I shouldn't say a lot of them, there's a small portion of them that didn't really care for the WebEx platform and having to connect the VPN and all that stuff. So there were some instances where we had providers actually just kind of go out and do their own thing with solutions like Skype or Doxy, and they were bringing in their own applications. And really, I had to step in at that point in time and say, hey guys, I know WebEx may not be the silver bullet, but really it was a vetted solution. It's HIPAA compliant. We really need to stay the course with this particular platform. And so that was this is an interesting little hiccup that we ran into with our providers. On the workflow standpoint, we, of course, the biggest change for us was introducing a scheduling process for our virtual visits. What Verizon did, we designated 3 to 4 bilingual front office staff throughout our network, and they provided the scheduling piece. And a lesson learned for us as far as the schedulers were concerned is, given that they were kind of that first point of contact with our patients, we actually trained them up, from an IT perspective to provide that level of support to the patient, which helped out greatly. Our schedulers, they stepped the patient through the connection process, which consisted basically of an email link that was sent to them. And we also developed a user-friendly FAQ document that we emailed to the patient as well for support. And I had shared that with Kathy too. I don't know if there's an opportunity there to share that with the masses, but would be happy to share that document with you, although keep in mind it's WebEx centric, but helped us out quite a bit. A lesson learned on that front was we did need to remind patients to check their email filtering and junk mail folders, because oftentimes our WebEx virtual visit invite would land there and they couldn't find it in their inbox. So that was some commonality that we saw throughout our experience while troubleshooting with patients. We also had an audio only option for our patient, which was very important. I guess in my mind, the hope is that audio only visit will be reimbursable again at some point, because it really served a good backup option for our patients with connectivity issues. For the most part, bandwidth for us or our patients wasn't too much of an issue, but what was nice with WebEx is it had a great built-in tool to where we can actually see like a graph and monitor the connectivity both on the provider end and the patient end, and help troubleshoot that using that WebEx tool. It's coming back to Jordan, speaking of Jordan's comment earlier, ideally, again, a lesson learned in my mind is really we should have been doing more test calls prior to those virtual visits. That would have helped out immensely. And I think it's a change we're going to start incorporating within our workflow, is just to get that all done before the call is scheduled. So that's really it for us on the virtual visit side of things. We've got a number of other initiatives happening on telemedicine. We are involved with other service delivery options like behavioral health. Behavioral health is our biggest use case for telemedicine, and obviously easily rolled out through our WebEx platform. We also have a great technology to present patients among our own clinics in the event we're short a provider or need help with patient overflow in a real busy location. So we're really excited about that. That to me it's probably a session in itself. And we're also using the same technology to present patients now to nephrologists and endocrinologists in the bigger health systems. So excited about that effort. And lastly, teledentistry is an area that we've been exploring, have had some good success with that. And fortunately, we were able to roll out teledentistry without a whole lot of additional software or hardware. We basically did it with all the equipment and using the WebEx platform. So that actually proved to work fairly well. And I could foresee us doing a lot more teledentistry in the future. So really, that's all I had in a nutshell. Appreciate your time, and feel free to reach out to me. I would be happy to share anything as it relates to either workflows or even some of the technology we have in place. So again, thank you, and feel free to reach out.
Thanks, Scott. There was a question for you in the chat here about which EHR Verizon uses.
Sure, we are an Eclinicalworks user. And again, I didn't mean to throw them completely under the bus. I know my staff are telling me that there definitely are some improvements on the telehealth side of things. So we're excited to see that to the point where, like I said, we're going to revisit that solution and may go that route and move away from WebEx for our acute care visits.
Are there any other questions for Scott? Feel free to type in or unmute.
There's a question about, does Verizon do Medicare wellness visits via telehealth?
Not yet, although I think we need to go there. In fact, we're having some pretty deep conversations lately. My concern is when you start to see companies like Amazon and Walmart and some of these large companies offering acute care services as well as annual wellness visits, I see that's on their kind of menu. And just from a competitive standpoint, I think we're gonna have to, but we're not yet.
Thanks, Scott, so much. We also have Wendy here to talk about another experience from another FQHC with rolling out telehealth technology. So Wendy, are you able to share your screen?
Sure, let me see. Thank you so much for having me today. Let's see if this works. Are you able to see everything okay?
You can see it.
Okay, perfect. Okay, my name is Wendy Vieira. I'm Director of Operations for Behavioral Health for Neighborhood Healthcare. And just real quickly, we're an FQHC in Southern California, where we have about 18 clinics in San Diego and Riverside County. We serve about 78,000 unique patients a year with about 385,000 visits. And we've been around for about 50 years. So we're fairly large. And as I was listening to Jordan and Scott talk, a lot of my stuff may even be redundant, but it was just reminding me of so many other lessons learned. So I definitely have not captured everything here, because it just kind of brings it back, everything we were all pushed to do quickly. Let me make sure I can forward this. There we go. Okay, so the reason why I mentioned how large we are is because depending on what your size is, your team may look very different. And we had been doing some telehealth just for behavioral health, but in California, we had a 4 walls rule where it meant that we could only do telehealth from one clinic to another clinic with provider and patients in our 4 walls in clinics. So it was nothing like it looks like today, where we can do telehealth in someone's home or have the provider at home as well. So the stuff we had done, we had these big clunky carts from clinic to clinic. But now with the emergency orders, the 4 walls have gone away. And of course, we can provide telehealth now. Different from what Scott was saying, we can still provide telephone visits. For behavioral health anyway, they are still billable through 2022. So we continue to do that. But these are some of the things that we had to do for our team members. So if you're a large FQ, you need to think very widely how you use people, and also be super flexible in how you think about people. Initially, none of us knew what to do. We had to furlough people and repurpose their positions. But a lot of folks that were those public facing positions, those patient facing positions that check people in or out, well, now they can still do a lot of that, but they're doing it over the phone. Or instead of the folks that used to do all of our universal screening, they can still do that over the phone. Our medical assistants, instead of doing their vitaling and med reconciliation, they can do a lot of that over the phone and ask the patient to get on the scale or see if they have anything that they can measure their temperature, things like that. And then, of course, their medication reconciliation. We changed some of our patient service rep positions into just schedulers. Scheduling had become a huge thing because we were scheduled out for months. And so the other thing that we had to think about is, how do we call every existing patient now and tell them they're not coming in person, that it's going to be telephone or video, educate them on the various platforms. As Scott had talked about, so we're Eclinicalworks also. And we had tried many things. We had tried our EMR and the WebEx. And then the same thing happened with our providers. When we sent them home, they started using their own Zoom or Doximity or DoxyMe. all the different things. So actually now we're all over the place. We're using a myriad of HIPAA compliant platforms. But I agree it would be much easier if we did choose one. So a lot of our team now, we had to think very differently from what we used to do in the clinic, where we also have translators. So in one of our regions in San Diego, we have a very large Iraqi and Chaldean population that are Arabic speaking. Very different from the majority. About 60% of our patients are monolingual Spanish speaking. So now we had to incorporate all of that through telehealth. And instead of using our on-site staff, because now with social distancing, we had to send a lot of physicians home. Now we had to figure out how to incorporate those into the telehealth visit or the phone call visit, and depending on the one of like 5 different platforms we were using. So we initially started out, I think, you know, now is the time, if you are not a provider that's using telehealth, now is the time to do it before you're sort of thrust into this like we were with COVID, where we were just kind of forced to figure it out really quickly, and we stumbled for many weeks and months. And now we're doing pretty good, but it's still, it takes time to work out a lot of the kinks. Some of the kinks for us were there were a lot of platforms out there that allowed you to use their platform for free. And that was great through 2020. But then once 2021 came and these platforms realized that everyone's using them now, well, now suddenly they limited the number of visits you could have for free, or the number of minutes you could have before they would disconnect you, or you had to pay for licenses. So those are things that you all need to consider as you go forward. And one of the things, I think it was Scott that mentioned also, we had the same issue with VPN. Originally, we only had very limited people working remotely. And so we were had a certain amount of VPN licenses. Well, now we had to just exponentiate that like crazy and get a lot more licenses in and expand our bandwidth and broadband as well. I think it's important that you also think of part of your team. We had 2 different teams. We have our IT team that can definitely help with some of the connectivity issues. But then we also had our EMR team, which is we call them our ECW team, but for purposes of if you have a different platform, because there are some people that were trying to use our EMR as part of our telehealth. And so those people were the experts that could really help with those kinks. And then our IT individuals helped with other issues. One of the things I recommend that we learned, we ended up having a tiered system with our IT folks. So we had some IT folks that say they were in the tier 1 of really kind of simple connectivity issues, you know, most of them that can be resolved with turning your system on and off type thing, that they would help. They needed to be immediately available by phone, or, you know, we've been using Skype and Teams to get someone. Again, we don't have time for tickets when we're starting this. It was a little chaotic. And then we had those more complex problems that we would run into that required some of our higher skilled IT team. And so you may want to think about how you design your IT team to support telehealth. Oops, I'm hearing some feedback. So for communication, the other thing throughout all of this for the last year and a half, I cannot stress enough how much you need to communicate and recommunicate and recommunicate and recommunicate. We have had to do, things were changing literally weekly, and workflows were updated, and then we'd have to change them again. And people would get sick and leave, or have to take time off because of their kids not being in school or whatnot. So, and then we constantly had to cover many different positions, or people had to stretch and cross train and provide coverage all over the place. And so, you know, to have updated workflows on some sort of SharePoint site, I think is very important for you, because we don't have time necessarily to educate everybody or all 700 employees, you know, what the new workflow is this week. And so if you have one main site, like a SharePoint site, to have all your main docs, and that's one source of truth everyone goes to for whatever the situation is. The other thing to think about is that live time, we needed to be able to provide oversight of ourselves as we're creating the processes. So part of what we had to do is we had to be able to track whether this is a telehealth visit, whether it's telephone, whether it's video or in person, change our visit types in our system, and then work with our billing on the back end to make sure that everything was billed correctly. Now, what we didn't realize at the time, but something to think about, we keep data on everything, productivity and all sorts of things. And so where normally our providers would, each one of our 18 clinics has their own budget. So, I'd have a budget for my providers in this building. Well, now my providers in this building, that's my expense, but also when they do visits, that's my income too, right? Well, now they're providing visits for all my other 18 sites. So now on the back end, it gets really confusing because my clinic is, the budget wise, is paying for the expense, but the visit types, if we're saying that their visit is at one of the 17 other sites, then those sites are getting that income coming back in. So it creates a whole lot of problems. And the only reason I bring that up is because I want you to just kind of think widely downstream. We didn't think of these things at the time because we're just solving the need, which is provide the service to meet the demand. But later you need to think about how this really unravels a lot of our reporting, all of our productivity type reports on the back end, even through our payroll. We had to now figure out how many hours worth of minutes are dedicated to each site now instead of the one site they supposedly work at because they're at home. It really has screwed up a lot of things, not to mention a lot of the grants that I have that are dedicated to specific sites. Now it's very difficult to track those visits dedicated to those programs because now they've kind of dispersed. So something to think of. You really need to think about how you want to, in your workflows, how you want to assign what type of visit types, and think about your reporting and downstream things like billing. Care coordination, I can't say enough about that if you're not doing it now. Obviously during COVID, social determinants of health, that's that SDOH, have become a tremendous need. So even though we are a healthcare clinic, we are not a social service agency. If we don't address the social service essential need that these people have, they're not going to get better. I don't care how great we are, and we are really, really great, but our people aren't going to get better if they don't have food, if they can't get their prescriptions refilled, or they don't have electricity and housing. And so we spent a ton of time, our outreach coordinators and our PSRs, our schedulers, doing a lot of care coordination, social services work. We had to get people connected with resources so they wouldn't get evicted, or so we had food delivered to their home, things like that. So think of telehealth widely. It's not just the service you provide, right? But it's meeting that whole person need. So I'll go on real quickly, sorry. Lessons learned, way more lessons than this. But some of the main things are learn to think widely and how you repurpose staff. One of the things we do in each of our job descriptions, oops, did my video just go off? Sorry. Oh, there it is. Hold on. I hit a button. Oh, I can't get it to go back.
We're still seeing best practices.
Okay, good. Now is it on the lessons learned?
Yes, it is. Yep.
Okay, perfect. So one of the things that we add to all of our job description, I'm sure many of you do too, is we always have like an extra thing that says something to the effect of, performs duties as assigned. I think that's really important to put on every job description, especially for things like this, because we had to repurpose people. A lot of them were doing jobs that had nothing to do with the job description that they were hired to do, but it was how we kept people employed also. And we needed staff to, we created a whole new senior outreach team that never existed before. And they were calling, we had 8,200 seniors. They were calling seniors every single week. We want to make sure, because with a lot of our seniors, they are being specifically isolated out of family concern for their safety, right? So family even wasn't visiting them. And, with seniors, once they get isolated, they get increased depression. A lot of them aren't mobile. So now they don't have the food or resources they used to have. They don't have the social connection with their family or friends. So we had a whole team that would go out there and call them, and there was 9 different categories. They would ask them things. We want to make sure they have their medication. If not, we're going to work with their pharmacy to have it delivered. And we could get that refilled. We would connect them to talk with their provider if they had questions, also to dispel a lot of the misinformation around COVID. They would ask if they had any symptoms. We would ask if they were depressed, lonely, isolated, things like that, or connect them with our behavioral health providers. So anyway, there were a series of different things we would talk about if they had any food insecurity. And then we had some social service partners we worked with that would literally deliver bags of groceries to their door and then knock on their door and walk away. So think widely of how you can use people and in an emergency. And it's actually neat because now a lot of these things are just part of the staple services we provide. and people still need those services. And also as different money and funds came in, we work with a lot of homeless individuals. And so a lot of our services now started being working with our community partners to put homeless individuals in hotels, either wellness hotels to keep them off the street to reduce spread of illness, or we'd work with the county. They had sick hotels to put individuals that needed to quarantine for 2 weeks. So we would do different things like that. And there's also been a ton of funding in our counties to pay for back rent if people had lost their job and needed to pay for rent and things. And so I only mention that as that's part of behavioral health as far as I'm concerned in telehealth. You need to ask your patients these things so you can provide them help. Things that we didn't think about. So now we had to do consent completely differently. And I'm happy to give that to Kim and she can send out later. That is something we built in a telehealth template that providers could merge into their provider note. And it already had pasted in a consent that's appropriate for telemedicine and basically said kind of the limitations of this, and that we are using HIPAA compliant platforms, but there's also, when you're using cell phones and things, there's limitations and you can't control complete privacy. And so there's a whole consent about that they have to go through. We had to change our visit types because we had to think ahead reporting wise. We never knew from month to month whether emergency orders were going to be extended or revoked. And so we had to keep track of the type of telehealth, whether it's video, in person, or telephonic, and still continue to do that. Things we didn't anticipate, teaching empathy to our providers. I mean, that was just a weird thing we didn't think about. But when you're talking to someone on the phone, a lot of our providers didn't understand how to really demonstrate empathy over the phone, or even if they're video, even our behavioral health providers, you have to learn to show a lot of more expression on your face rather than just, and you can't really be plain. So we had to teach a lot of sensitivity skills, and we had a consultant that assisted us with that. We also had to teach basic things. A lot of our providers type and talk at the same time. So we had to talk to them about not doing things like this as they're having a session, looking sideways, right? Typing while they're doing their session. So it just took time. We had to think about, like I said, as of January, all these systems we were using suddenly started charging or limiting us, kind of forcing us to buy the licenses that we needed. So think about that ahead of time when you start vetting what system may work for you. Test connectivity, I won't go into that. Scott and Jordan both spoke about that. Really important, because at first we sent our providers home and they had to increase the speed of their connections and their bandwidth, but then school stopped. And so, where at first they thought they had enough, well, now you've got 2 or 3 kids and now your spouse is at home also working from home. And if they're all on video and they're on video during the classroom, it slows things down. So it's important, just think widely. Don't just test for one person. Think about, well, what if now I have multiple users at home on the same router and things? You just need to kind of test this. And if you can test it ahead of time, that's really what you should do. We were thrown into this, so honestly, we learned trial by fire. So just think about that signal congestion that I talked about. If you have multiple people at home, it changes how much data can be sent, like whether your videos are pixelated or your mouth works at the same speed someone's speaking. One lesson that we also learned too, originally we had, out of our 18 sites, we had one building where our IT hub was, if you were, and we had everything there, all of our servers, everything. We're not doing that any longer, because guess what happens when the hub goes down? So now we are going to put servers at each of our clinics so that if one site goes down, they all don't go down. Something to kind of consider. Some of the best practices real quick that we've learned. At our site prior to COVID, only a few people we didn't offer remote access because that's not how in California we're paid. We're only paid for face-to-face services that are in our clinic, in our 4 walls. We weren't allowed to do telehealth. Telehealth is just between clinics, remember. So most of our systems in our offices were desktop systems. That has completely changed. Everything now is laptops. And then with our IT department, we couldn't even order laptops because everything's backlogged, as you know, for everything. So now every single new position, every position this whole last year, we buy laptops for everyone. And when you get laptops, you put remote access and VPN in each one of them. So that way we are prepared. We're not going to be caught in the situation we were here before. The other thing I recommend, think about stockpiling monitors, cables, laptops, headphones, webcams. When we first started this, we were totally unprepared. So people at home were using whatever kind of webcams we had, like Scott was talking about. We had the kind where you take pictures, but that's not enough for 700 people, to take home and do what they do. So we had a heck of a time getting things. There was many delays in getting equipment. So I recommend stockpiling some of that so you can be more effective. The other thing is, instead of repurposing your staff, think about repurposing your equipment. So one of the things that we had a lot of were tablets. We had tablets in all of our clinics because we would use them for patients to do all of the universal screenings, or even we had some for express check-in and different things, or satisfaction surveys, things like that. Well, now they're not being used because we didn't have patients there. So this is a picture of what we've done with some of them. We put a hotspot on them and we attach them to basically on wheels. And so now what happens is this MA is doing her part with the patient while she's doing the med reconciliation and trying to do what vitals she can. And then she's walking, instead of rooming a patient, she's walking it in to that provider's office. A lot of our providers still provided telehealth services, but from the clinic office. The other thing we had a shortage of is Wi-Fi hotspots. I think that's something you need to think about stockpiling as well. And then I already talked about the last two things. The last thing that I wanted to add, if you want, just because we don't have enough time here, one of the things, since we're in California, we work a lot with the California Telehealth Resource Center, and we finished a project where our providers made these short videos. So it is really meant just to be from provider to provider, to basically talk to you about lessons learned through telehealth. So you're going to get some really honest feedback. Like some of the videos are 5 minutes, some are 8 minutes, where a provider is going to say, hey, this is what I thought when we first started. I didn't think I could do it. These are the struggles I had. Here's how I was able to adapt. Or you have some providers say, hey, I loved it. But they're really candid because it really is meant to be that provider to provider. So they're going to tell you really what they thought about it and what they learned. In addition to that, they have special populations that they show you how to work with telehealth, considerations you may want to think about. So there's some videos on refugee populations, how to work with children in telehealth, how to work with seniors. That could be a whole talk in and of itself, because seniors have a great deal of technology changes and challenges. Even if you have people that can call and walk them through the process, it's still incredibly difficult. So we have videos on that, or working with trauma, undocumented individuals, things like that. So go check that out if you're interested on the California Telehealth Resource Center website. Aside of that, I know there are many other things we can do, but I'll just leave it open to questions at this point. Thank you for your time and attention. Kim or Kathy, you back with us?
Yeah,
Okay.
I just wanted to give folks a chance to unmute if they wanted to ask a question.
Okay, great.
There was a question, Wendy, I'm not sure if you saw it in the chat here,
No,
about the empathy training that you did, and if you created the curriculum independently, or if you had an outside resource for that.
I had an outside resource for that.
Okay. And if you're willing to share that, I can also put that into the resources
I didn't know if we were
section.
allowed to say names. That's why I wasn't. But Elizabeth Morrison, she is a consultant, and that's all she does is empathy training. She did tons of different empathy presentations, and she has even a provider toolkit that she shares on her website as well.
Great. We'll include that in the resources section so that folks can find that website.
Okay, great.
And thanks so much for sharing the other resources and links in the chat as well. Give folks just a minute.
I can send you that one page also,
Sure.
if people want to know what the consent is that you kind of paste in, and different scripts that you talk about.
Yeah, that would be great. Thank you.
Sure.
I was going to make a comment per Wendy's mention about provider etiquette. Some interesting things we've seen on our end is the patient etiquette when they're seeing their provider from home. Oftentimes we've run into instances where the patient will be washing dishes or grocery shopping. And in one case, one patient was in the bathroom. So there's this whole different dynamic happening on the patient side that is making things kind of interesting.
That's actually part of our consent, that we've told people they need to find a private space. Like our behavioral health people will actually cancel sessions if they're driving, or if there's because we consider that not being able to be HIPAA compliant. Like if they're walking in the grocery store and things, we've actually ended sessions because other people can hear what they're talking about. So it's just to protect their privacy as well.
Oh, great idea.
Yeah. We also educate them to find a quiet space, close the door, you know. And we have plenty of patients, as you say, to have their session in the bathroom. Not that they're going to the restroom, but just it's a quiet place away from the kids.
It's the only place I can hide from my kids.
Right.
All right, I'm gonna, on that note, I'm gonna stop the recording. If there's anything else that folks are interested in learning about, or if there are resources that you would like for us to help to locate or to contact the speakers to be able to locate those resources, please feel free to email that same email address that sent you your reminder. I'll receive the email and then we'll make sure to get those resources to all of you. Thanks again for joining us. We have another session next week, our last session in this 4-part mini series. But also I will say we have thought of a lot more topics to cover. So we may in fact be doing future mini sessions or an even longer series in Project Echo for these topics. Wendy and Scott, thank you so much for your presentations. I want to make sure is Jason still here? Okay. Jordan, you're still here. Okay, good. Jordan was gone and came back. Hi, Jordan. Jordan, thank you so much as well for your presentation. What great content. And I will be putting up the recording of this session as soon as it's available to me, which is probably later tonight or tomorrow. So keep an eye out for that on the resources page. Thanks again so much, everyone.